kinds of individuals that may have received more treatment if the patient rights legislations were really redesigned. We often try to get people on an involuntary assessment or have police involvement for safety concerns. Aside from there being issues with behavioral health legislation on what you can and cannot do with people to protect their individual rights, there's also issues for police officials and what they're allowed to do. They may know of someone like the gentleman who had a lot of violence and was thought to be mentally ill that locked the child in the bunker that we just got out, that he was a high profile member of the community with lots of issues, and yet not incarcerated, not institutionalized for involuntary evaluation and all of that. So I think that it needs to be a multi-pronged approach if we're really going to address wanting mental health stability in the general community. It's not always an access issue. Sometimes it really is. People recognize it. There are little requirements that, aside from being acutely homicidal and grossly psychotic, that get you an involuntary stay, and then when you're released, there's very little legislation that requires you to continue treatment as an outpatient. So those are things that I think would really address a lot of mental health issues here. Child and adolescent beds, changes in legislation that would allow us or somehow require police and mental health to, and the judicial system to insist on or enforce outpatient compliance with treatment so that folks are adequately treated when they're living in these deinstitutionalized community settings. So, thank you very much. Turning over to the inpatient guys now, which is the next part of the behavioral health.
Our service segment of this kind of fragmented continuum of care is much smaller. What we provide at City Hospital, which is part of WVU, so we're the faculty hospital in the region, along with our sister hospital, Jefferson, which is a critical access hospital in Jefferson County. We work with them quite a bit. They also provide crisis assessment services. They have no inpatient beds at that critical access hospital. We have licensed for 30 beds at City Hospital. We currently have 19 beds available. We are expanding that to 23 beds in the next 3 months. We have a very limited scope of, well, our scope of practice actually isn't limited, but our ability to admit people is quite limited. You have to be a danger to yourself or others, much like the gentleman in the bunker or some of the other people that we've talked about. You have to be homicidal or suicidal and voluntary to come to our unit. We can take involuntary patients as well. And as Paul said, we work with Sharp, the state hospital, to take diversions from people in this region. We have approximately 140 assessments a month that we do. We admit about 65 patients to our inpatient 19-bed unit a month. That's up considerably from last year, which was about 40 inpatient admissions. So the volume keeps growing. We have just started to keep data on adolescent and child referrals and assessments, which we also do. We do assessments for them, however, we do not have beds. We're not licensed to take adolescents and children. But we do about 22 adolescent assessments a month. And all of those children that come into our ED department have to be referred somewhere else. So typically they go to Brooklyn or Chestnut Ridge, which is also part of the WVU system. A lot of the families in this region don't want to send their children to Chestnut Ridge because they can't be part of the treatment process, which is a requirement to do. So they have to really go to Brooklyn, which is the only game in town, so to speak, finally get discouraged with their grandparents, their parents, and go home and basically try to keep that child safe. and then come back the next day while the child is still unsafe, trying to get admission to an inpatient unit. And these children are, definitely admittable. That 22 number are people that are actually admitted to the unit, and you have to be a danger to yourself or others in order to be admitted. So it's not as it used to be years ago, where you could get admitted to an inpatient psychiatric unit as a worried well person. You have to be acutely psychotic or suicidal or homicidal in order to be admitted. We also see a large number of our patients, I would say at least 40%, if not 50%, are co-occurring disorder mental illness patients, and that just means that they have more than one issue going on, and typically it's a primary mental health diagnosis with a substance abuse co-occurring disorder. So most, well, like I said, 40 to 50% of our assessments, we have to doubly treat them, so to speak. So we provide master's level process groups on the unit for mental health issues, schizoaffective disorder, major depressive disorder, and co-occurring substance abuse disorders as well. So it's an interesting milieu. It's an interesting place to be. There's a lot of different presentations there. It's very fragmented in some ways. It's difficult for patients that are in different socioeconomic areas. They have a hard time getting along with different folks. We take everybody, so insurance. We prefer that people have insurance, Medicaid, Medicare, but we take people that are self-pay. Our current rate, self-pay is really no insurance, is about 20%, 25% of our patients come in with no resources. We do provide services that get them resources, and we get about a 40% rate of those folks that eventually get Medicaid or Medicare as a result of it. But our length of stays are very short, unlike the system that Paul at East Ridge and Shenandoah. We have 9-day length of stays. So we have people that show up in our emergency rooms that are extremely acute. We do crisis stabilization, medication management, some basic group activities of daily living type activities, and referral sources. So we try to refer those folks out into an outpatient practice. We have 3 psychiatrists, WVU faculty. They have an outpatient practice over in the Dorothy McCormick Center. We do not have a therapist at this time in that treatment setting, which we do need. And we're talking right now about bringing therapists into that outpatient practice. We're talking about bringing some substance abuse treatment, detox, and an intensive outpatient program into the hospital, but that is literally months away from happening once the decision has been made. And I think for us, the biggest gaps that we have in the system are referring people out to an outpatient appointment. And remember, someone that comes into our hospital is extremely acute. They have, on average, about 9 days to get them stabilized and into some type of an outpatient practice, which, as Jeannie mentioned, can be 3 weeks down the road or longer in some cases. And that patient really has no resources. Our actual outpatient is even longer to get people into our outpatient practice, and we have no therapists there. We just do basically medication management. And a lot of times, the patients that come to us, their no-show rate for that first appointment to the outpatient therapist is very, very high. So they potentially can be 90 to 180 days before they actually see a therapist again. So what happens is a lot of our patients just recycle back through the emergency department, It's constant. We see the same patients all the time, constantly. Within a week sometimes within 3 weeks, but it's a revolving door, so to speak. That to us is very troubling, because a lot of those people don't survive not seeing an outpatient therapist. A lot of those people don't survive coming back to the ED. It's a very long process. You come through the door at City Hospital, and you want to get admitted to the behavioral health department. The average time it's going to take you to do that is 4 hours. It's a long time. It's about a national average, but it's still a long time for someone to sit there that's acutely suicidal or homicidal or psychotic. Once they get on our unit, it's a safe place, it's locked, but it's a very difficult place to be for patients, especially if they're not psychotic, if they have major depressive disorders, and they're working with a lot of psychotic patients. We can't control the types of patients that we have that are on the unit at any given time. Referral sources, getting people to outpatient is our biggest problem. We have, just as an example, one patient that has a very complicated schizoaffective disorder, borderline mentally retarded patient, who's been on our unit for 5 months. And it's not someplace that we would want someone for 5 months. And there just is no place in West Virginia. We're looking in all of West Virginia to find for this young man to go to. He's, relatively violent, so people don't really want to take him there. And the process to get waivers and all these types of things, and surrogates, and all that, very, very cumbersome process. Substance abuse issues we do provide detox services by default because it becomes a medical emergency when you're talking about alcohol and benzodiazepines. But we treat it at City Hospital as a medical emergency, so typically those patients end up on a medical surgical floor with very little contact with behavioral health at the time when it's probably the most beneficial for them to be talking to a mental health professional. So we do go up, our crisis workers go up and talk with those patients while they're being detoxed. Typically, that patient does not get admitted to our unit, but they get detoxed and then they lead to some form of outpatient practice that may or may not exist. And as you're hearing from these two, it's very difficult to get those services. We have thought about a crisis stabilization unit for adolescents. We see a lot. We don't see a lot of the kids under 10, but we see a fair amount of adolescents. So we have thought about doing that as just a stopgap in the system. But again, our length of stays would be relatively short. They'd probably be a little bit longer than 9 days. They'd probably be about 2 weeks. But the reimbursement rates and trying to keep the financial viability of the hospital running while doing that, it's a very difficult business model to maintain and keep everybody employed and keep nurses working and all those kind of things. So I think, I would just reiterate what Paul and Jeannie said, that we need a continuum of care. We're a small part of it, but the crisis stabilization piece is a pretty big part of it, but we don't have any place to send people when they are stable, so they become unstable very quickly. And they have medications when they leave, but the medications typically, they get them to their first outpatient appointment, which they don't make a lot of times, so they recycle back through the system. And that's if they don't, complete a suicide in the process, which does happen quite frequently. So it's definitely a broken system, and I'm not sure exactly what we do governmentally to make that continuum of care work. I know that we talk a lot about trying to get patients admitted into outpatient practices, and we work with East Ridge and Shenandoah, and they are very accommodating to a lot of our patients. A lot of their patients come to us who are in crisis and need inpatient stabilization for a short period of time, then they go right back to them. So that part of the system works fairly well, but folks that aren't in it really are not getting the services they need to get.
And we found too that on the new patient intakes, the no-show rates that are high are quite often associated with transportation issues. And I can't emphasize enough how expanding the transportation. We have offices in Berkeley Springs and Charlestown, so we see a huge problem with the Morgan County folks in transportation and keeping appointments, but we also see a lot of that in both Jefferson and Berkeley County, and that is an issue that the community as a whole could really probably impact a lot of, not just behavioral health, but a lot of other things, activities for kids after school and so on. It would be helpful to really focus on things.
That's true. We also provide ECT services. That just reminded me that a lot of our patients that do ECT, we do about 70 to 80 ECT, electric convulsive therapy, for patients. And a lot of times they miss their appointments, and it's important once you're in the system, when you're doing ECT, to continually do those. And they live too far away to drive, so there's no transportation for them